When you're on 100% of FiO2, the PEEP is 10, and your pulse ox is 89, where else do you go from there?
Yeah, the point here is that when you have this patient who's sick, this is where you're going to come park your computer, sit down,
Yes.
and you're going to do this in front of this person's room because you really shouldn't be.
You have essentially $30 to spend. So if you want to keep your plateau less than 30, and you spend $15 on 15 a PEEP, you only have $15 left over to spend on your plateau pressure.
What's up, and welcome to Talking Shift. This is the brand new podcast that we're rolling out where we're going to talk about critical care and resuscitation in longer format. And for the first episode, I'm going to bring on somebody who you may have seen on social media, and that is Plum Toilet, Nick Ghionne. Is that right?
You got, yeah, especially with the hand motion, that makes it like all the more better. So
yeah, it's forgiving for any detail accent.
Yeah.
Well, thank you for being here with us today. We're going to be talking about something that is very difficult for some people to manage, and that's refractory hypoxemia. You see a patient who comes in, you start managing them, you think you're doing okay, and then the blood gas comes back, the SAT starts dropping, you do some things, but the patient's just not getting better. And so I think that's something that everyone finds trouble with, and we brought you on today to help us out with that. How's that sound?
Sounds great. Can't wait.
So let's get right into it, and maybe we should just start off with a hypothetical case. And we have a 62-year-old male who comes in short of breath with cough, and turns out he has influenza, and this x-ray looks absolutely horrible, diagnosed with ARDS, gets intubated, and there he is on his initial vent settings. We'll make some stuff up. We just say that his PEEP is 14, is where they landed on. FiO2 is 100%. His tidal volume for 6 cc's per kg, it's arguable whether or not it should be lower, but we'll just say it's about 470,
Right.
and his respiratory rate is set to 16. But this guy's blood gas is not getting better. His SATs aren't any good. I guess the first question I have for you is, what would be your first maneuver with this patient?
So my first go-to is I need to assess on the mechanical ventilator how much this patient is participating. And that's important because whenever you have a patient who's participating on the mechanical ventilator, it makes your measurements inaccurate, and it can cloud a lot of things and confound things. What happens normally is the patient gets put on the mechanical ventilator, we go to 6 cc's per kg. But remember, that's almost invariably going to make the CO2 rise. So just from a practical sense, what you're doing is causing asphyxiation, right? Not sort of like an extreme term, but we breathe in response to CO2. So if we're forcing it to rise, the patient could be breathing faster, could be breathing deeper or harder, double triggering maybe. So the first thing is to get an assessment on how much the patient's participating. Once I have that, and let's say that they're on propofol, they're sedated and appropriate RAS, not participating that much, then I'm going to look for my pressures. So the first pressure I'm going to look for is the plateau pressure. I'm going to look at the plateau pressure. The way that I think about it, you have $30 to spend, right? So if you want to keep your plateau less than 30, and you have to work PEEP into that equation somehow, the PEEP is setting your floor. So if you spend $15 on 15 a PEEP, you only have $15 left over to spend on your plateau pressure, i.e. your total volume. So depending on what this total volume is getting me, plateau-wise, mixed in with the PEEP will tell me what I need to do next. So that's one section. What is the plateau? What is the total volume in my ml per kg is sort of a ballpark. What is my blood gas on this? And then from those three things, I'm going to have to figure out how I can negotiate the plateau, the PEEP, but also the blood gas. Because you can go in and make it 3 ml per kg, right? Like there's nothing stopping you from making it 250, but your CO2 is going to suffer as a result, and your pH, and you're going to get acidotic and hypotensive and all that kind of stuff.
I like this approach because what you're doing is you're basically saying, let's get a clean slate when we're starting off. Yeah, there's so many variables that are happening. The patient might be doing some mechanics, and you're assessing pressures off those mechanics.
Exactly.
So let's just wipe this with a clean. Let's get a clean set of values. And what you're saying is by sedating the patient, I guess in extreme cases, paralyzing temporarily,
Exactly.
right? Just so you can see what their waveforms are and assess what their pressures are.
That's exactly right. I not infrequently give 1 dose of rocuronium just so I can get my mechanics where I am at mechanics wise, because patient effort, especially in ARDS, just makes things worse because they're breathing at a place of their residual volume. When we talk about the lung volumes, we're at FRC, which is what your lung volume is at the end of sort of a passive exhalation. So what I need to do is assess the ventilator graphics, assess the waveforms, see how much the patient's influencing that. If they have too much influence over it, then I have to take a timeout and they got to, get on the bench and let us decide what we're going to do with the pressures.
Great. I really like that. So let's go through now and start getting to brass tacks. So now you've sedated the patient, right?
Yeah.
And you got the patient in the place that you want them. What are some of the things that you're doing to assess where the patient is at? Let's talk about some of the strategies that we're going to use for this patient. And one of the things that people might have heard about is this concept of driving pressure. So what I want you to do, if you can, is give me the definition of what driving pressure is. Give me the concept of what driving pressure is and why we should or should not be using it. And then tell me for this particular patient who's on a PEEP of 14 right now, and what was his plateau, did we say? Did we talk about his plateau?
We didn't talk about a plateau, but
Yeah, I'll give you his plateau is 32. Okay, so now we have plateau pressure. Work me through how you're going to use driving pressure in this particular case. But start off with the concepts, please.
Yeah. So driving pressure mathematically is the plateau pressure minus the PEEP. After the Yamato study in ARDS, they retrospectively looked at that study and saw that there was a benefit of mortality if that number was less than 15. So essentially, it's as easy as getting the PEEP and then getting the plateau and subtracting them. What it is as a concept is, if you imagine the alveolus is sort of like this, right? At the end of inspiration, it's sort of stretched out to here. Now, let's say your PEEP is 5. Now it's going to go to here, right? But let's say we go inspiration again. So we're going to go to here. And let's say we made the PEEP 10. Now it's going to go to here. What you are preventing is atelect trauma. So you want to avoid this cyclic opening and closing of the alveolus. You want to avoid this because, remember, the lung is a one-celled structure. So more trauma to the alveolus exposes basement membrane and other factors that will propagate an inflammatory response, which essentially is what ARDS is in a lot of ways.
The way I've always thought about it, and maybe the way I was taught, is that you don't really know where you are with that when you're measuring your plateau pressures. You kind of don't know where you are on that pressure volume curve. But what you do with driving pressures is you're changing the PEEP, because that's the thing you can actually change. And that tells you where you are on the curve. So perhaps in this case, maybe we have too little PEEP and we need to drive that PEEP up to get more recruitment of the lung and better compliance. Or there are some cases where maybe the PEEP is too high and that driving pressure is high, and bringing it down tells us that we were too far on that compliance curve. Is that the right way to think about it, or is there a different way?
That is the right way to think about it. And what is PEEP? So positive end expiratory pressure. It's the pressure that we sort of leave in the circuit at end expiration that provides recruitment for alveoli.
Let's go through this example. So the patient's PEEP right now is 14 and the plateau pressure is 32. So let's say we decide to increase the PEEP to 16 and see what happens, right? Typically, when I'm on rounds and we sort of want to make a decision, this like how fast do you increase the PEEP is always a hard thing to know. Some, people do it over 2 to 3 minutes. We can all agree that's probably too little time to see a meaningful change. And then if you wait 15 minutes, which some of the studies suggest, or longer, that's also too long to make a meaningful change and make some decisions on your hypoxemic patient. But let's just say we somehow find this magical amount of time. We make this change. We go from, here we are at a PEEP of 14 and we go to 16. And let's say that our driving pressure now comes down. Let's say it was 18 and now it's coming down to 16. Does this tell you now that you're moving in the right direction and this PEEP challenge is the way to go?
I'm going to probably park the PEEP there and see what I get in another 15 minutes to 30 minutes.
Yes. So now it's coming down. Your driving pressure, we'll say, is coming, your driving pressure is coming down to 16. What does that tell you?
That tells me that we are recruiting lung.
Good.
You can prove that to yourself. If you wanted to prove to yourself that it's getting better, you're recruiting lung, theoretically, if you got a repeat chest x-ray, it should look better. So for me, I don't usually do that. That's something you can do if you want to sort of prove it to yourself. But if all things are equal and nothing has changed with the patient, i.e. they're not like really participating in breathing or anything like that, if the plateau pressure is getting better in the face of increased PEEP, that has to mean that the compliance is improving, i.e. the plateau pressure is getting better and you're recruiting lung.
Fantastic. Do you ever have a PEEP where you're like, I'm going to start going down first before I start going up? Because I think when people start to get into high teens, they have a little bit of fear, even though that lung might be so de-recruited that they need to increase the PEEP.
Yeah.
Some people are still afraid. Do you go down first to try and prove it to yourself, or you're like, nah, I'm Nick, I'm going up?
No, I never go down the PEEP. I got to tell you, I never go down. The only time I would go down is there is a possibility if it's too much PEEP and there's a lot of pressure in the chest, you could be sort of squeezing off the pulmonary circulation, which will give you sort of this paradoxic worsening ventilation and hypoxemia. So if I felt in some way that that was the case, I might come down the PEEP. But honestly, sometimes you have to like go up and get the lung, right? It's de-recruited. It's away from you. You have to go up and get it. And the only way to do that is to supply PEEP. And I tell the residents and the APPs I work with, when you're in this situation, like this isn't like a set it, forget it, I'm going to the call room, call me if there's anything wrong. Like you have to be actively in the room checking the pressures because you are using the ventilator as your main modality. When you have these high settings in ARDS, I think you're almost required to be in the room every hour, 90 minutes, the most.
Yeah. The point here is that when you have this patient who's sick, this is where you're going to come park your computer, sit down,
Yes.
and you're going to do this in front of this person's room because you really shouldn't be leaving and outsourcing that information. You got to be at the patient's bedside, and this is very dynamic measurement.
100%.
You mentioned APRV, and let me just simply explain what APRV is for people. So with APRV, for those of you who've heard that term before, it stands for airway pressure release ventilation. And what that is essentially is what's called an open lung strategy. Imagine, if you will, if you have these patients who have ARDS or whatever de-recruited lung, a lot of that lung is just socked down and it's very difficult to open it up.
Right.
So the concept behind APRV is if you provide a constant pressure to that lung, over time, that de-recruited lung is going to slowly open up. All that atelectatic lung is going to open up. Think about it as basically just constant CPAP. In fact, that's really what APRV is, right? It is a constant positive airway pressure that you're applying to the lung. So you apply that to the lung, you hold it over time, and then those small alveoli slowly start to pop open and get recruited back into that ventilation. And you could do this infinitely, except for the fact that patients have to breathe and they have to breathe out CO2 every once in a while. Otherwise, they would just become acidotic and die. And so what APRV is, for very brief intervals, for a fraction of a second, there's a release of that pressure where the lung can derecruit, or I don't want to say collapse, that's a scary word, but come down and force out some CO2, and that's the respiratory phase. Only for a fraction of a second, and then reinflates again, and then provides that constant pressure. And what happens over time is those alveoli open up, and they start to now participate in gas exchange again. And it's one of those modes where you have to be very, very patient with. It's not an instant gratification. I tell people, set your APRV, and then go have some coffee, and come back later. And the only thing you have to worry about with APRV, of course, is there could be more acidosis, so you have to be mindful of that. And then because of the immense amount of intrathoracic pressure you're providing your patients, you have to be mindful of hemodynamics. Is your patient's blood pressure going to go worse? As Nick said before, are you going to have more alveolar distension causing more pulmonary vascular resistance, which is going to increase afterload on the right ventricle? These are all real things that you have to be mindful of. So it's a great mode of ventilation to keep in mind when you have that patient who's so refractory and you just want to open up their lungs. Let's move on and talk a little bit about some of the other adjuncts that we have.
Yeah.
And these are a little bit more controversial. We're talking about things like nitric oxide or epoprostenol.
Yeah.
Nick, where do they fit in your algorithm? I mean, my understanding is that there's no improvement in mortality, but they make the numbers look good. Where does that fall in your algorithm of managing your patient?
Yeah, they do make the numbers look good if the patient responds. I look at it like this. So when we teach the mechanical ventilator, our goal is to get the FiO2 less than 60% as to avoid oxygen toxicity. So for me, I like epoprostenol because if that buys me a little bit of oxygenation to get that FiO2 lower, we set the PEEP correctly, we're doing the low total volume ventilation, we're doing everything else correctly, we're influencing the compliance in other ways by treating the pneumonia, by maybe giving some diuretic if we think the patient's overloaded. But my FiO2 is still at 75%. That's still a toxic amount of oxygen. So if I can pop that EPO on and now the SATs come up a bit and I can titrate that O2 down, I think it's worth it personally.
And for those of you who are like, well, what's the difference between the two? They both work kind of the same. Nitric oxide is just tremendously more expensive, and so hospitals usually restrict it.
Yeah.
But they both work to cause pulmonary arterial vasodilation, and so the numbers look better because you're getting more blood flow through the lung. All right, last thing we're going to talk about, and this is something that a lot of people are afraid of, and I don't know why, and that's proning.
Yeah.
Certainly with COVID and everything that happened, a lot of people were found themselves in the position of learning how to prone patients.
Yeah.
But what's the data in proning? Is it like kind of meh, or is it really good? And where does this fall in your practice of the person with refractory hypoxemia?
It's the only other thing that we can do that can influence mortality is proning, as by Prosiva. So if you ask the question, what can we do to influence the mortality in ARDS? The two things are low total volume ventilation and proning. A lot of it has to do with the toxic FiO2 setting. So if I'm above 60%, and there's numbers, right? If you're sort of have to be below 150 for the P to F ratio. So if you got a blood gas and you got the number, let's say it was 100 in the PaO2 on the gas, and let's say you're on 100% FiO2, only because I can't do math, that would be zero point 0.1. So then the P to F is 100, which is moderate to severe ARDS. So certainly below 150. The data would tell us to prone that patient. So Prosiva did the 18 and 6, so 18 on the belly, 6 on the back. Proning is tough. It's tough for a number of reasons. Number one is because if patients are bigger. Number two is deep tissue injury happens all the time. Number three is it's very easy to, like, the tube can sort of maneuver its way out if you're not really paying attention to where it is. So you have to be careful about that stuff. So for me, it's hard not to prone, especially now that we've had so much experience, I think, doing it, like as providers. If I'm in the situation where the patient's on toxic FiO2 and there's no reason for me not to prone them, I mean, I'm proning them because it's a mortality benefit. How could you sort of not do it?
So it sounds like there's mortality benefit to it. There's a lot of physiologic benefits to it.
Yeah.
There's hemodynamic benefits to it. There are pulmonary benefits to it. There's a diuresis component to it. There's so many good components to it.
There's a
that I encourage
secretions
people.
component to it because the way your trachea is pitched, when you are on your belly, you can get the secretions out better. So there's a lot of reasons to prone. Yeah.
So people shouldn't be afraid to prone. That being said, it should be done in a situation where you do have protocols in place because, as Nick said, there are line and tube dislodgements that happen. There are pressure sores and deep tissue injuries that can happen. But that being said, the benefits for it are immense, and I think that many more patients than we're proning are candidates for that. So consider it in your department.
Yeah.
All right. So we talked about this case of the guy who came with refractory hypoxemia. What I'm looking from you is just a quick rapid fire stepwise approach for how you're going to approach this person. Let me get in your head and say, like, stepwise approach globally, not in detail.
Yeah.
But are we starting with driving pressure first? Are we starting with epoprostenol? Are we starting with proning? What's your order of attack for this patient?
You have to personalize the ventilator. So while we say 6 cc's per kg, there's a lot of variables that work into that. Driving pressure is certainly one. Plateau pressure is certainly one. Other things come into play. So I have to make sure that the ventilator is sort of tip top. I have the 6 cc's. They are meeting the goals of oxygenation ventilation. After that is when I sort of starting to sweeten the pot. Maybe go up on the PEEP and see if you can buy any driving pressure with it. I make sure the ventilator is set to appropriate settings, meeting the goals. Then we'll move to other things, treating underlying causes, maybe diuresis if I think the patient's overloaded, to try to influence the compliance. Then we start adding things on, like proning would be my next step because that has a mortality benefit. After that is probably where I would add in epoprostenol because there's no mortality benefit. So I guess what I'm trying to say is I wouldn't do epoprostenol before I proned because the epoprostenol has no mortality benefit and the proning does. So I prone first, and then if I still need to buy some oxygen, I'll throw on epoprostenol and see if that gets me anything.
It sounds like the first thing is do the basics. Make sure that you're really optimizing your vent. Make sure you're looking at driving pressures. Even doing APRV if you find that if it's a better strategy for your patient. That's step number one.
Yeah.
And steroids and paralytics and all that's kind of mixed in there too, right? But you're not going to do the epoprostenol first because that could possibly give you a false sense of security that, oh, this person doesn't need to be prone now because their PF ratio is better.
Right.
When in fact, there's no mortality benefit for it.
Right.
But proning your patient first early on gets you that mortality benefit.
Exactly.
And at that point, your patient is still hypoxemic, then going ahead and massaging the numbers, making them look better. Because at that point, you've really done everything you can.
Yeah.
And we haven't even mentioned VV ECMO, which we're not going to talk about today because not every place has that, but that'll be a talk for a different day.
Yeah.
Nick, you got any closing thoughts before we wrap this up?
Severe hypoxemia is scary because the patient's hypoxic, you just increase the oxygen and the number comes up. Now, whether that's a good or bad thing, we'll sort of leave that to the side. But when you're on, 100% of 502, the PEEP is 10, and your pulse ox is 89, where else do you go from there? So that's really when you have to hunker down and try to understand what the ventilator is doing, what the patient is doing. In that situation, if the patient was at it, like sort of breathing fast or really participating, that's when we just have to take a time out, a short dose of paralysis, so I can get the mechanics down, and then I can influence what I need the vent to do based on good mechanics. Because if the patient's participating a lot, it's going to make these numbers untrustworthy.
That's great summaries. Let me just see if I can wrap this all up. So we're taking our patient out of the picture to make sure that the numbers that we're looking at are actually the numbers that we want to use. And then we're being aggressive about manipulating the ventilator, doing PEEP strategies, driving pressures, again, looking at alternative modes of ventilation, proning our patients early, and then going ahead and doing Epoprostenol for our patients who are refractory. Is that correct?
Yeah, that's my general approach.
Fantastic. Nick, it was so good to have you on. Hopefully you'll come back on Talking Shift with us again. And for those of you who want to find you on the social medias, where do they find you?
Most actively on Instagram, same handle, Poem Toilet. Also have the YouTube that sort of starting to build it up. Still have X, although sort of migrating away from that in some ways, and also have Blue Sky, all the same handle, Poem Toilet.
And don't forget, Resus X is going to be happening this year, September 29th to October 1st in Philadelphia. And we're going to have Nick coming down for our post-conference mechanical ventilator workshop. So you can also find him there.
Yep.
Nick, thanks so much for being on.
Can't wait. Thank you, sir. Appreciate it.
All right.